This recorded lecture will be going over Chapter 23, Care of Patients with Brain Disorders. Seizures can be symptomatic of a large number of disorders, including brain injury from a stroke, pressure from a brain tumor, infectious diseases with high fever, end-stage renal disease with uremia, toxicity, epilepsy, and tetanus. Seizures also can occur anytime the brain is deprived of oxygen. Metabolic disturbances like acidosis, electrolyte imbalance, hypoglycemia, hypoxia, and water intoxication can cause seizures. Alcohol or barbiturate withdrawal can cause seizures. In children, a high temperature is a common cause of seizures. Epilepsy is a chronic disturbance of the nervous system characterized by various types of persistent seizures that are the result of abnormal electrical activity in the brain. Epilepsy is characterized by recurring seizures thought to be caused by a group of abnormal neurons firing spontaneously, resulting in excessive excitation or loss of inhibition. Seizures are classified based on three key features: types of seizures at onset, awareness during the seizure, and motor or other symptoms present. Classifying seizures into different types helps with diagnosis and appropriate treatment. Focal seizures, previously called partial seizures, affect only one part of the brain, leading to localized clinical symptoms. Generalized seizures involve both sides of the brain, and usually the whole body if motor symptoms are present. Generalized seizures are divided into motor and non-motor, known as absence seizures. Generalized seizures include absence, myoclonic, clonic, tonic-clonic, and atonic seizures, as well as infantile spasms. Sometimes patient may have no warning, or they could have an aura. This is a preceding sensation. Absence seizures may last only a few seconds. The onset will be sudden, with no aura or warning, and no postictal symptoms. There is typically twitching around the eyes and mouth. With tonic convulsions, there is continued contraction of all muscles, and the body becomes rigid. The patient may be incontinent during the attack, and there is danger of biting the tongue. In the postictal phase, this occurs after the seizure, the person will be confused and drowsy. Status epilepticus indicates prolonged partial or generalized seizure activity of 5 minutes or more, rather than just one seizure without recovery between attacks. Status epilepticus is a grave condition in which there is a rapid, unrelenting series of convulsive seizures without any intervening periods of consciousness. This can include an absence of respiration. Irreversible brain damage can occur if the seizures are not controlled. Diagnosis of epilepsy is based on the history and actual signs and symptoms observed during a seizure. EEG and magnetic or MRI can be helpful in identifying or ruling out the cause for a seizure. The diagnosis will be made when metabolic abnormalities, toxins, infection, or other reversible causes have been ruled out, and two unprovoked seizures occur more than 24 hours apart. When the cause of seizures is known, as in cases of high fever or drug toxicity, medical treatment is aimed at controlling or eliminating whatever is responsible for the seizures. For recurrent seizures, as in epilepsy, the condition usually is managed with anticonvulsant drug therapy. All anticonvulsant drugs cause some degree of CNS depression with grogginess, dizziness, fatigue, and cognitive changes. A ketogenic diet provides sufficient calories from fats and proteins, but produces a ketotic state that seems to prevent seizure activity. Status epilepticus is a medical emergency, typically caused by abruptly stopping anti-seizure medications in a patient with epilepsy. Care will be focused on supporting vital signs and preventing injury. Surgical procedures involve removing the epileptic focus or preventing the spread of epileptic activity by focal cortical resection. For intractable focal seizures, vagal nerve stimulation therapy can be effective. On page 541 in the purple focused assessment box, we can see some observations to make when observing a seizure. Significant history information would include the kind of seizures the patient experiences, whether they have any sensation just before the appearance of the observable signs, what medications they are taking, and what measures have been known to be helpful either to prevent a seizure or assist during the seizure as well as afterwards. In many cases, a change in the neurologic status of the patient can signal the possibility that a seizure might occur. Maintaining therapeutic blood levels of anticonvulsant medications is extremely important in the prevention of seizures. Excuse me. Witnessing a seizure for the first time can be a frightening experience. Your first responsibility is to stay calm, remain with the patient, and call for assistance. If the patient is very likely to have seizures, the side rails and the headboard of the bed should be padded. Never try to pry open the patient's mouth or insert anything into the mouth once the jaw has clamped down, because the teeth could be broken and the airway could become obstructed. If a seizure comes on without warning and the patient drops to the ground, do not attempt to move them. The head should be protected from injury by placing a rolled blanket or coat underneath it. The head should be turned to the side, if possible, to prevent aspiration of secretions. Remove glasses if present, and do not attempt to restrain the patient's movements in any way. Stay with the patient until they have completely regained consciousness. After the seizure, they should be allowed to rest or sleep. The long-term management of epileptic seizures is primarily focused on providing the patient with the information and support that they need for self-care and to how to avoid recurring and debilitating seizures. Self-care for an epileptic patient requires that they understand the nature of their disorder, the purpose of their prescribed medications, the side effects, and signs of toxicity that should be reported to the healthcare provider. Patient compliance with the medication regimen and avoidance of triggers for seizure activity are evaluated as well. Transischemic attacks, or TIAs, are caused by a brief interruption of blood flow. TIAs are a warning that a more serious neurologic event may occur. 10 to 15% of patients who experience a TIA will have a stroke within 90 days. During the TIA, the person may feel a sudden weakness or numbness on one side of the body, slurring of speech or inability to talk, visual disturbances such as blindness or double vision, confusion, diminished coordination or ability to balance, and a headache. Symptoms are similar to those of a stroke. These symptoms generally resolve within 24 hours without a residual deficit. Anyone experiencing symptoms of a stroke should have an immediate assessment according to the American Heart Association guidelines. This includes assessment using the NIH stroke scale within 10 minutes of arrival, a CT scan performed within 25 minutes of arrival and interpreted within 45 minutes, and then thrombolytic therapy, if indicated, should be administered within 1 hour of arrival. Stroke is the leading cause of disability and the fifth leading cause of death in the United States. The incidence is about 19% higher in males than in females. Control of high blood pressure, quitting cigarette smoking, decreasing intake of cholesterol and controlling blood lipids, maintaining a normal blood sugar level, avoiding excessive alcohol intake, getting sufficient exercise, preventing obesity, and living a lifestyle that prevents heart disease can all help reduce the incidence of stroke. Atherosclerosis is a major cause of stroke because it can predispose the thrombus formation in the brain vessels or plaque in other arteries that could break off and become emboli. Stroke can happen in two ways, hemorrhagic or ischemic. The most common cause of stroke is ischemia. Ischemia of cells directly causes cellular necrosis and infarct. Ischemia can be caused by a cerebral thrombosis or an embolus. On page 544, you can read some information on the Green Health Promotion box about the dangers of cocaine or methamphetamine use. The carotid arteries supply a major portion of blood that goes to the brain. If plaque forms in these arteries as a result of atherosclerosis, the person is at risk for stroke as the blood supply to the brain is diminished or stopped. Atrial fibrillation is a common cause of embolic stroke. The second mechanism of stroke is an intracerebral hemorrhage. This is where a blood vessel ruptures and leaks into the brain tissue, or an aneurysm or AVM in the brain leaks or ruptures. If a patient needs an endarterectomy, which is a removal of a clot from the carotid artery, as an intervention for stroke prevention, it is only performed when carotid obstruction is greater than 60%. Structures that can cause an intracerebral hemorrhage are an aneurysm and an AVM, or an arteriovenous malformation. An aneurysm is an abnormal ballooning of an artery wall. An AVM, or arteriovenous malformation, is a congenital abnormality, and it is a tangled mass of malformed, thin-walled, dilated vessels that form an abnormal communication between the arterial and venous systems. Subarachnoid hemorrhage, which refers to bleeding in the brain below the arachnoid, often causes rapid onset of neurologic deficit, severe headache, and loss of consciousness. A leaking cerebral aneurysm can cause a severe headache. Many strokes can be prevented either by surgical procedures or by medical management of diseases that predispose a person to CVA. Management of AFib is important in stroke prevention. Control of hypertension and the effective treatment of inflammatory heart disease, congenital heart defects, cardiac dysrhythmias, and atherosclerosis have significantly reduced the incidence of stroke. Aspirin or other antiplatelet drugs to reduce platelet aggregation and decrease the chance of thrombosis will often be prescribed to prevent the reoccurrence of stroke due to thrombosis. On page 545, 545, in the blue patient teaching box, you can read about the warning signs of a stroke. The neurologic effects of stroke can range from mild motor disturbances to profound coma. Signs and symptoms will likely depend on the type of event that has caused the stroke and the location of the occlusion or bleed. There may be weakness, known as hemiparesis, or paralysis, known as hemiplegia. Difficulty or inability to speak or understand, known as dysarthria or aphasia. Difficulty with coordination or a loss of balance is known as ataxia. Motor function deficits will affect mobility, respiratory function, swallowing, speech, gag reflex, and self-care abilities. Keeping the body in good alignment to prevent contractures is very important. Many stroke patients who experience dysarthria, which is a difficulty in speaking, due to lack of muscular control of the tongue. The frustration of trying to perform a function that was always easy before the stroke can cause the patient to cry. Alternatively, the patient may display an angry emotional outburst and sometimes use foul language. Memory and judgment can be affected by the stroke. Spatial perceptual deficits can cause the patient to totally neglect input from the affected side of the body. This is termed unilateral neglect. They must be taught to attend to the body parts on that side of the body in order to protect them from injury. Hominis hemaniopsia is a blindness in the part of the visual field of both eyes. This will add to spatial perceptual problems by making it difficult to judge distances. Agnosia is the inability to recognize an object by sight, touch, or hearing. Apraxia is the inability to carry out learned sequential movements on command. Bladder and bowel incontinence are often temporary after a stroke, and with time, these problems can be overcome. A CT scan will rule out a hemorrhagic stroke. It will not confirm an ischemic stroke because the tissue changes will not be visible until after the time frame for treatment. An EEG will be performed, brain scans or a transcranial Doppler flow study, and carotid artery can also be performed. A hemorrhagic stroke will be diagnosed with a CT scan or an MRI. Elevate the head slightly to reduce ICP. Hypoglycemia should be evaluated and treated because hypoglycemia signs and symptoms can often be similar to those of a stroke. The NIH stroke scale is the most commonly used scoring tool and is implemented during the initial assessment to determine severity of deficits and whether thrombolytic therapy is appropriate. In addition to the CT scan, an EKG will be obtained and blood is drawn for lab testing to determine treatment options. Recombinant tissue plasminogen activator, or RTPA, can be used to dissolve clots and emboli in an ischemic stroke. It must be administered within 3 to 4.5 hours of the onset of symptoms. If TPA has been given, no anticoagulant or antiplatelet aggregation drugs should be given for 24 hours. This drug will not be administered to anyone with a known history of bleeding or who has had a history of intracerebral bleed. Hypertonic saline can be used in the place of mannitol in patients with hemorrhagic or ischemic stroke to reduce ICP. Blood glucose levels will be monitored and controlled. A thrombectomy using devices inserted percutaneously to trap and remove the clot can be used up to 8 hours after the onset of an ischemic stroke. The interventional radiologist or neurologist will perform this procedure during angiography. If it is successful, blood flow can be restored to the brain within 20 minutes. There are risks of bleeding associated with these procedures, and they must be considered. A cerebral aneurysm can be repaired during a craniotomy by placing a clip around the stalk of the aneurysm. AVMs are treated in much the same way, but they may be eliminated using radiosurgery. About 1/3 of all strokes can be traced to obstruction of any one of the 4 arteries in the neck that supply blood to the brain. If occlusion from plaque obstruction is less than 60%, typically medical treatment with diet and lifestyle modification will be prescribed, as well as medication to prevent platelet aggregation, such as Plavix or aspirin. Carotid procedures are typically not done emergently as a treatment for stroke. Neurologic assessments will be performed often to monitor closely for any signs of increasing ICP. Increased ICP occurs most commonly with subarachnoid hemorrhage. Neurologic signs in LOC will be watched closely to detect deterioration of the patient's condition due to further bleeding and a risk of a rise in ICP. Seizures are a common complication of a stroke because neural pathways are interrupted when blood flow is blocked or there is irritation of the cerebral cortex from an intracerebral bleed. If seizures occur, they are treated with standard anti-seizure medications. Hydrocephalus is common when a subarachnoid hemorrhage has occurred. Care of patients who have had a stroke is described as occurring in phases. The initial hospital care, rehabilitation efforts begun in the acute care setting, then a transition to intensive rehabilitation as either an inpatient or an outpatient, and community-based rehabilitation. There will be overlapping of activities in each phase. Assess the stroke patients for risks of falls, and institute appropriate interventions to prevent falls. A nutritional and dysphagia screening should be completed within 24 hours of the patient being awake and alert. Use an established stroke scale to evaluate any deficits that are present. Because a patient who has had a stroke is at risk for a second occurrence, assessment for new signs of neurologic impairment is ongoing. Planning for specific goals must take into account the patient's previous lifestyle, age, general health or illness status, and specific problems of care. The amount of activity permitted to a stroke patient during the initial acute stage of their illness will depend on the cause of the stroke. When there is no danger of further damage to the brain, the patient is typically encouraged to become active as soon as their condition has stabilized. This is to maintain independence. This picture can be seen on page 550, showing the comparison of deficits and behavior related to damage of right and left sides of the brain. A speech therapist should be consulted for a swallowing study and to devise a plan to improve swallowing. When the patient has had dysphagia, aspiration when eating is a real danger. Measures to prevent complications, like subcutaneous low molecular weight heparin injections and sequential compression stockings to prevent DVT, skin care to minimize the risk of skin breakdown, physical therapy, and splinting to prevent contractures and spasticity, as well as measures to prevent falls, should be included in the complete plan of care. Plans for rehabilitation should begin the moment the patient is admitted. This means proper positioning, range of motion exercises for affected limbs, adequate nutrition and fluid intake and output, prevention of pressure ulcers, use of devices to keep extremities in anatomic position, and all other nursing measures directed towards maintaining normal body functions until the patient is able to maintain them on their own. If the patient has homonymous hemaniopsopia, they will have a visual defect affecting the same half of the visual field in each eye. The patient should be taught ways to deal with their visual problem and teach patients who have unilateral neglect to bathe both sides of the body. The patient is typically transferred from the hospital to a rehab facility. Active muscle exercise will be necessary to retrain them. Instead of feeding the patient every item on their food tray, let them hold bread and other finger foods, suggesting that they feed themselves these things. If hemiplegia is causing the patient to pocket food in the folds of the mouth should be checked after meals. Combing and brushing the hair is a good exercise for the arm and shoulder, as are brushing the teeth and washing the face and hands. The patient who has sustained a brain injury becomes fatigued very quickly, and this must be kept in mind when performing self-care activities. Encouragement and praise for the smallest accomplishment can help the patient's tattered self-esteem. Stroke patients can be prone to rapid mood swings and spontaneous weeping. The degree of rehabilitation needed will determine the length of stay. After acute rehabilitation, plans are made for discharge and referral to individuals and agencies outside the facility that will help the patient and the family adjust to their new way of life. The patient continues rehabilitation as an outpatient under the healthcare provider's supervision. More than 700,000 Americans are living with a brain tumor today. Metastatic tumors from a different site of origin occur in 10 to 30% of adults with systemic malignancies. Most brain tumors are benign and not cancerous. Neoplasms within the confines of the skull are space-occupying lesions and thus create problems of increasing ICP by compressing adjacent tissues. However, because of increased ICP that tumors cause and the way that they can invade brain tissue, a benign tumor also presents a serious condition. Primary malignant brain tumors will rarely metastasize outside of the brain. The symptoms will depend on the location and they could appear gradually, or if the tumor is a high malignant, fast-growing type, they may appear suddenly. In a slow-growing type of tumor, the patient may first show personality changes, disturbances in judgment and memory, loss of muscular strength and coordination, or difficulty in speaking clearly. Headache awakening the patient is a key sign. Approximately 20 to 50% of adults with brain tumors will develop seizure activity. Diagnostic procedures to identify the site and extent of intracranial tumors include skull X-rays, MRI, and CT scans. The three modes of therapy for intracranial tumors are the same as those for neoplastic diseases elsewhere in the body. This includes surgery, radiation therapy, and chemotherapy. Radiation can be delivered as a whole brain radiation therapy, stereotactic radiosurgery, or brachytherapy. Most chemotherapy drugs cannot cross the blood-brain barrier. To get the drugs into the brain circulation, an Ommaya reserve may be implanted between the scalp and the skull. Chemotherapy drugs can be injected into the port and instilled into the CSF in the ventricle. Surgery can be used to remove intracranial tumors, and then additional modes of treatment can be used to destroy remaining cells. Sometimes, however, the tumor has infiltrated vital parts of the brain that must not be traumatized by surgical procedures. If the tumor cannot be removed entirely, a portion may be removed to relieve compression of the brain against the skull. Pain assessment and control are important. Complications include hydrocephalus. This is the obstruction of CSF flow and could require placing a shunt to reduce CSF pressure and prevent increased ICP. A shunt is a tube placed in a ventricle of the brain and attached to a valve system that opens when the pressure from fluid rises to drain the excessive CSF from the ventricles to the peritoneal cavity or into the atrium of the heart where it can be reabsorbed. You can see a really good picture of this on page 557. It is figure 23.10, showing a ventriculoperitoneal shunt to drain excess CSF into the peritoneal cavity, where it can then be absorbed through the mucosa. Additional complications include intracerebral hemorrhage and seizures. Meningitis is an inflammation of the membranes covering the brain and spinal cord and is caused by an infectious agent. Viruses, bacteria, and fungi can cause meningitis. Fungal meningitis occurs mostly in patients with AIDS. Infection can spread from the spinal cord or sinuses to the brain. Two examples of how infectious organisms could enter the cranial vault other than through the bloodstream include through an opening in the skull from a head injury or surgery, or by accidental introduction of infectious agents into the spinal canal during a spinal puncture. Immunization of all young adults against bacterial meningitis is recommended. ICP will be elevated. Meningitis can cause permanent neurologic damage or death if not treated properly. The most obvious symptoms of meningitis are sudden onset of fever and a severe and persistent headache that is greatly aggravated by moving the head. Other signs of meningeal irritation include pain and stiffness of the neck when flexing the neck, exaggerated deep tendon reflexes, irritability, photophobia, and hypersensitivity of the skin. A positive Brudzinski sign can be elicited by placing a hand behind the patient's head and with the other hand on the chest, gently flexing the patient's neck forward by moving the chin towards the chest. If there is flexion of knees and the hips, when you try to flex the neck, the Brudzinski sign is positive and indicates meningeal irritation. Meningococcal meningitis is commonly accompanied by a petechial rash covering the chest and extremities. Seizures are also typical, as are nausea and vomiting. When meningitis is suspected, a lumbar puncture is performed and the CSF examined for the number and type of organisms present. A Gram stain will identify the causative organism. Successful treatment of meningitis and prevention of permanent disability will depend on early recognition and prompt treatment. Antibiotics are started immediately for bacterial meningitis, And when the causative organism has been identified, specific antibiotics to which that organism is sensitive will be administered. Dexamethasone, along with antibiotics, has proven beneficial to decrease inflammation for many patients. It should be given prior to the first dose of antibiotics to prevent damage from the intense inflammatory reaction caused by substances released from the massive amount of bacteria killed. Death will occur in about 25% of cases. Several viruses can cause meningitis. The most common are enteroviruses, arboviruses, HIV, and herpes simplex virus. Viral meningitis tends to be milder than bacterial meningitis. The disease is typically self-limiting and is managed symptomatically. Full recovery typically occurs within 7 to 10 days. Assess the patient for subjective and objective data relevant to each of the patient care problems that may accompany the disease. Examples include seizures, elevated body temperature, nausea, vomiting, pain, increased ICP, and fluid and electrolyte imbalances. The patient's room should be quiet and dimly lit. Sudden noises or bright flashes of light could cause a seizure because the sensory input activates nerve impulses. Care and treatments are coordinated to allow for as much rest as possible. Fluid volume deficit is a common problem. The patient will need support and reassurance because the severity of this illness is frightening. Once the acute stage of the disease is over, the patient can gradually resume their former activities. Encephalitis is less common than meningitis. It is an acute inflammation of the brain that is serious and sometimes fatal. Some of the viruses responsible for encephalitis are associated with seasons of the year or with geographic locations. Ticks and mosquitoes are the vectors that transmit the disease. Post-viral encephalitis is an immune-mediated disorder and follows the end of the viral infection by 2 to 12 days. The severity of illness may be mild or fatal. The most common types of viral encephalitis in the United States are caused by herpes simplex virus 1, West Nile virus, and the enteroviruses. If treatment for herpes simplex encephalitis is not started before coma occurs, death is almost certain. The onset of encephalitis may be sudden or insidious. There may be behavioral and personality changes and a decreased LOC. Stiff neck, photophobia, and lethargy are classic symptoms of encephalitis. Seizures, acute confusion, and flaccid paralysis may occur. Encephalitis symptoms differ from those of meningitis in that with encephalitis there is altered mental status, motor or sensory deficits, and speech or movement disorders. Diagnosis is confirmed by the presence of the virus in the CSF or bloodstream. A brain biopsy can also be required to verify the responsible organism so that proper treatment can begin. The treatment of encephalitis is primarily symptomatic, with general supportive measures to maintain cardiac and respiratory function, maintain the patient's strength, promote healing, and prevent complications. Permanent neurologic disabilities may occur, like problems with walking, paralysis, cognition, memory, and self-care. A brain abscess is a collection of purulent material in the cavity of the brain. A brain bacterial infection that has traveled from the gums or teeth, sinus, ear, or mastoid regions to the brain is typically the cause. Signs and symptoms include headache, fever, and progression to lethargy and confusion. If the abscess is not treated, ICP will rise as the size of the abscess increases. A combination of antibiotics is used to eradicate the abscess. Surgery may be required to drain the abscess or relieve ICP. Headaches are the most common cause of complaints of pain. Headaches are commonly caused by allergy and related sinus problems or by tension, or they are vascular in origin. The pain of a headache may be minor or severe. Persistent headache requires testing to rule out organic problems like anemia, brain tumor, or cerebral aneurysm. Treatment for severe recurrent headaches begins with determining the cause, if possible, and identifying factors that seem to precipitate the headache. Approximately 30 million Americans have at least one migraine headache every year. The actual mechanism is not known. Attacks will typically occur irregularly and may begin with an aura, like a visual disturbance or spots between the eyes, known as scotoma. Many patients with a migraine do not have an aura preceding the attack. Pain will typically begin on one side of the head and is described as throbbing in character. Symptoms could last for 44 to 72 hours. Treatment involves preventative measures as well as intervention for acute pain. Lying in a darkened, quiet, odor-free room with the eyes closed decreases the symptoms. Prevention strategies help decrease sensitivity of the neurologic system, preventing new attacks. If migraine headaches tend to occur around the time of menses, hormone therapy can be effective in preventing the headache. A cluster headache causes the most severe headache pain. The pain has an abrupt onset and usually lasts 30 to 90 minutes. The headache may recur several times a day, and the clusters usually last 2 to 3 months. Alcohol can trigger this type of headache. Signs and symptoms include severe unilateral, orbital, supraorbital, or temporal pain, along with one of the following: redness of the conjunctiva of the eye, tearing, nasal congestion, dripping nose, facial swelling, pupil constriction, or ptosis of the eyelid. History is usually sufficient to diagnose a cluster headache, but CT, MRI, or magnetic resonance angiography can be performed to rule out tumor, aneurysm, or infection. Treatment for cluster headaches includes a combination of analgesics and 100% oxygen by face mask, sumatriptan succinate, and other triptans, intranasal lidocaine, or oral ergotamine. Tension headaches are not as severe as migraine or cluster headaches. Analgesic medication, muscle relaxants, tension reducing medication, or relaxation techniques such as massage, yoga, and biofeedback can often be helpful. Trigeminal neuralgia is a relatively rare facial pain syndrome. In 80 to 90% of cases, the pressure is caused by an abnormal loop of an artery or vein. Trigeminal neuralgia involves one or more branches of the fifth cranial nerve. The most notable symptom of trigeminal neuralgia is severe facial pain, which is described as sharp and intense, lasting for 1 to 2 minutes, and located along the pathway of one or more of the branches of the trigeminal nerve. Attacks are typically triggered by exposure to drafts, light touch or vibration, drinking cold or very hot liquids, chewing, brushing the hair, shaving, or washing the face. The pain during an acute phase is so severe that many patients live in constant fear that they will do something to provoke an attack. Diagnosis is based on the patient's history and chief complaint, and on tests to rule out a cerebellum-pontine angle tumor that is affecting the nerve. There is no test to confirm this diagnosis, and there are no observable pathologic changes. Medical management usually is preferred to surgical intervention. The drugs typically prescribed to prevent or relieve spasmodic pain are the anticonvulsant medications carbamazepine and oxcarbazepine, and the muscle relaxant baclofen. Microvascular decompression is a surgical procedure for those patients with a known compression of the nerve that can be surgically corrected. The patient will be very sensitive to any contact with the face and will indicate the area of pain by pointing to it but never touching it. Because chewing can provoke an attack of pain, the patient may be susceptible to nutritional deficit. Nursing interventions for a patient who is being treated medically include instruction about the expected actions and adverse effects of prescribed medications. Surgical treatment of trigeminal neuralgia results in a potential damage to the cornea when the ophthalmic branch is dissected. They should get into the habit of wearing protective goggles when there is the possibility of getting dust or debris in the eye, and they should try to blink their eyes as often as they can to cleanse the surfaces. The patient cannot feel hot liquids and foods that could be burned. They could bite the inside of the mouth without realizing it, or they may have dental caries that do not cause pain. Good oral hygiene and periodic dental examinations are particularly important when the body's natural warning system is not operative. Bell's palsy is a weakness or paralysis of the muscles supplied by the facial nerve. It usually affects only one side of the face and typically occurs in people older than 30 years. The herpes simplex type 1 and herpes zoster virus are believed to be a cause, and stress can also be a factor. Signs and symptoms include numbness and partial or total paralysis of the facial muscles that could occur suddenly or over a few days. Diagnosis is by a patient history and the exclusion of other neurologic or muscular disorders, as well as Lyme disease. If the patient is asked to raise the eyebrow on the affected side will not move. Treatment consists of closing and patching the eye if it loses the blink reflex. Artificial tear drops are also used to prevent dryness of the cornea. Corticosteroids can be given if they are started right after the beginning of symptoms. Acyclovir can be prescribed as well because herpes virus may be a causative organism. Bell's palsy will recur in 10 to 15% of patients.